Viral infections. Most important viral skin infections include herpes simplex, herpes zoster, warts, molluscum contagiosum. Herpes simplex. It's a very common viral infection, if not the most common infection at all. It's caused by herpes simplex virus, a DNA virus. There are two types, herpes simplex virus type 1 and type 2. Type 1 leads to herpes labialis and other non-genital infections, while type 2 leads to herpes progenitalis. It's transmitted through skin-to-skin or skin-to-mucous membrane contact. Type 1. First episode. It usually occurs in the first years of life. In 90% of the cases, infection is subclinical and passes unnoticed, while in clinical lesions appears in 10% of the cases, usually in infancy and young children, in the form of primary herpetic gingival stomatitis. Small superficial vesicles develop on the oropharynx, rapidly rupture, leaving painful erosions. Lesions heal within 2 weeks, and they are associated with fever, malaise, loss of appetite, swelling gums, salivation, sore throat, and regional lymphadenopathy. Recurrent attacks. Following the resolution of primary infection, virus is not eliminated, but it migrates to dorsal root ganglia and remains dormant. If reactivated, viral particles migrate along peripheral nerves to the skin and mucous membranes. Recurrent herpes simplex at or near primary site. Predisposing factor for recurrence: fever, fatigue, trauma, ultraviolet radiation, stress, menstruation, GIT disturbances, and altered immune status. Sites of recurrent attacks: lips, face, and we have other special variants of herpes simplex type 1. Lips, herpes labialis, unilateral or bilateral grouped vesicles on erythematous base appear on the lips, preceded or associated with burning or tingling sensations. Within few days, they dry up, crusts forms which fall off, healing without a scar occurs. Face, or herpes facialis, around other orifices as nose, eyes, ears, as well as on cheeks. Special variants of herpes simplex virus type 1, ocular and herpetic whitlow on the finger. Ocular, they need consultation from ophthalmologist as they may lead to corneal ulceration and opacity. Herpetic whitlow or finger herpes simplex, it occurs on the finger due to direct inoculation of the virus into abraded skin, particularly seen in doctors and in nurses. It's very painful with vesicles, edema, and redness. Herpes simplex type 2, herpes progenitalis, the first episode, transmitted by sexual contact involving external genitalia in males and both external and internal genitalia in females. It's characterized by painful grouped superficial vesicles on erythematous base, followed by erosion or genital ulceration associated with inguinal lymphadenopathy. Herpes progenitalis in pregnant women at the same time of delivery is a strong indication for CS, as neonatal infection is very serious. Recurrent attacks. They are less severe than the primary infection. Complications of herpes simplex are secondary infection, eye complications, keratitis or corneal ulcers. CNS complications, encephalitis, meningitis are rare, but they are very serious, and they occur in neonates, infants, and children. Erythema multiforme due to recurrent herpes simplex virus type 1. Diagnosis by clinical picture, Dank smear using James stain, viral culture, serological tests, human simplex virus antibody test against type 1 and 2. Management: general and topical. General: avoid precipitating factors if possible to prevent recurrence, and avoid direct sexual contact during the attack. In genital herpes, silent viral shedding may occur between the attacks. Topical therapy: drying antiseptic lotions, potassium permanganate 1/8,000 to 1/10,000 or 10% aluminum acetate used in early vesicular stage. Antivirals, acyclovir cream, applied 5 times per day every 4 hours for 5 days. Effective when given early in the course of the disease, better in the prodromal stage, reducing period of the attack and duration of viral shedding. Systemic therapy, antivirals. We have acyclovir, valacyclovir, and famciclovir. Acyclovir, 200 mg 5 times per day every 4 hours for 5 days, administered within 48 to 78 hours from the appearance of eruption, given in severe episodes or immunocompromised patients. Prophylactic doses may be given when recurrences are frequent. Herpes zoster. Both varicella and herpes zoster are caused by varicella zoster virus. Chickenpox, varicella. It occurs in patients after primary exposure to the varicella zoster virus. It usually occurs in childhood, presents with crops of vesicles which develop brownish crusts, and heal within 2 weeks with or without scars. In adults, the infection is more serious with tendency to develop complications. After the attack, the virus resides in the posterior root ganglia. Herpes zoster, its reactivation or reinfection with varicella zoster virus. Predisposing factors are trauma, fever, immunosuppression by HIV, diseases of the spine, TB, and metastatic deposits, malignant disorders such as lymphoma or Hodgkin's disease. Clinical picture: onset is associated or preceded by pain. Unilateral groups of vesicles appear on erythematous and edematous base along the distribution of one or more sensory nerves. Local lymph nodes are enlarged. Vesicles dry up, forming crusts, and recovery occurs within 2 to 4 weeks. Clinical variants: hemorrhagic, gangrenous, generalized, and abortive. The generalized, all of which occur in immunocompromised patients, while the abortive type presents only with pain without any vesicles. Disease is usually not recurrent. One attack gives permanent immunity. However, rarely recurrences may accompany malignancies. Complications: secondary bacterial infection, post-herpetic neuralgia, particularly in elderly patients, persisting for weeks to months. Early start of treatment decreases the severity of this complication. Eye complications: uveitis and keratitis, which occur in the involvement of ophthalmic branch of the trigeminal nerve. Suspect internal malignancy in very old age, bilateral or generalized affection, recurrent herpes zoster, and hemorrhagic, gangrenous, or generalized types. Management: prophylaxis, varicella vaccine in children, zoster vaccine in elderly. Treatment: topical and systemic. Topical: drying antiseptic lotions such as potassium permanganate 1/8,000 to 1/10,000 solution or aluminum acetate 10% help dry vesicles. Systemic therapy: antivirals and analgesics. Analgesics such as NSAIDs, carbamazepine, gabapentin, and pregabalin. Antivirals should be started within 48 hours of the disease. Acyclovir 800 mg tablets 5 times per day for 7 days. Valacyclovir 1000 mg 3 times daily for 7 days. Famciclovir 500 mg 3 times daily for 7 days. If we're going to compare between herpes simplex and herpes zoster, the cause: herpes simplex type 1 and 2, while zoster is varicella zoster virus. Recurrence is positive in simplex and negative in zoster. One attack gives solid immunity. Primary lesion: unilateral or bilateral grouped vesicles on erythematous base in simplex, while in zoster is unilateral grouped vesicles on erythematous base. The site is mainly periorificial in simplex or along the distribution of the nerve in zoster. Distribution: unilateral or bilateral in simplex, while in zoster it's strictly unilateral, not crossing midline, linear along a dermatome. Lymphadenopathy: negative or positive in herpes simplex, but it's always positive in zoster. Complications of simplex are secondary infections, eye, nervous system, and erythema multiforme, while herpes zoster complications are secondary infections, eye complications, and post-herpetic neuralgia. Treatment: for herpes simplex, topical therapy, drying antiseptic lotions, acyclovir cream, and IDU for eye lesions. Systemic therapy: antivirals, acyclovir 200 mg 5 times per day for 5 days, valacyclovir or famciclovir. While herpes zoster, we have topical therapy, drying antiseptic lotions. Systemic therapy: antivirals, acyclovir 800 mg 5 times per day for 7 days, valacyclovir 1000 mg 3 times per day for 7 days, and famciclovir 500 mg 3 times per day for 7 days. Analgesics: NSAIDs, carbamazepine, gabapentin, and pregabalin. Warts or verrucae: they are common, infectious, benign epithelial growth caused by human papillomavirus. They involve both skin and mucous membranes, direct or indirect contact. Incubation period 1 to 6 months. We have 5 types of warts: common warts or verruca vulgaris, plain warts, verruca plana, filiform warts, verruca filiforms, plantar warts, verruca plantaris, and finally genital warts or condyloma acuminata. Common warts or verruca vulgaris: they are asymptomatic, skin-colored papules with rough mammillated surface. Plain warts or verruca plana: asymptomatic, skin-colored, flat-topped papules occurring in children, showing Koebner's phenomenon. Filiform warts or verruca filiforms, long, thin, pedunculated skin growth. Plantar warts or verruca plantaris involving the sole of the foot, usually tender, thick, growing inwards. Genital warts or condyloma acuminata involving skin of genitals in both genders. In mucous membranes, they are soft, pinkish, moist, foul-smelling outgrowth with cauliflower appearance. Oncogenicity may predispose to cervical dysplasia or carcinoma in cases of female genital warts, and they occur with human papillomavirus 16 and 18. The course, spontaneous involution, may occur within 2 years. However, progression and appearance of new warts is common. Treatment of few warts may induce regression of other warts. Treatment: electrocautery, tissue destruction by heat; cryotherapy, tissue destruction by freezing with cryogen such as liquid nitrogen; chemical cautery, tissue destruction by caustics such as carbolic acid, phenol, glacial acetic acid; trichloric acetic acid 40%, salicylic acid or lactic acid 40%. Podophyllin resin 25% in alcohol is used in treatment of genital warts. It's painted by the dermatologist twice per week and should be washed after 6 to 8 hours. It's contraindicated in pregnant females or in large bleeding warts. Laser treatment by carbon dioxide laser or pulse dye laser. Immunotherapy, imwikimod cream, which may be used in treatment of genital warts by stimulating local interferon production. And finally, we have molluscum contagiosum. It's caused by pox virus. Direct or indirect contact. Incubation period 2 to 6 weeks. Clinical picture: shiny, pearly white, dome-shaped papules, few millimeters in diameter with smooth surface and characteristic central umbilication from which a white, cheesy material is oozed on squeezing. Individual papule is few millimeters in diameter. It's common in children. Large lesions occur in HIV-positive patients. If it involves genital skin, it's considered STD, sexually transmitted disease, and it's highly transmissible. Multiple lesions can occur. Treatment: electrocautery, cryotherapy, chemical cautery, and laser. Other viral infections with mucocutaneous lesions include measles, rubella, German measles, rubella, hand, foot, and mouth disease, and HIV. And this concludes the viral infections. Fungal infections. Fungus is a class of organisms in the plant kingdom defective of chlorophyll. Fungal skin diseases are whether superficial or deep. Superficial affecting the epidermis, deep affecting the epidermis, dermis, and or subcutaneous tissue as well as internal organs. Superficial infections, they are among the most common dermatological disorders. The most common genera are dermatophytes and yeast. Dermatophytes such as Microspora, Trichophyta, and Epidermophyta. Yeast such as Candida and Malassezia furfur. Dermatophytes, they are known as ringworm or tinea, involving skin appendages such as hair and nails. Mode of infection: direct contact with infected humans or animals, indirect with barber shops or patients' fomites. Diseases caused by dermatophytes: Tinea capitis, ringworm of scalp; Tinea corporis, hairless skin; Tinea cruris, groin; Tinea barbi, beard; Tinea pedis, feet; Tinea manum, palm; onychomycosis, nails. Tinea capitis, we have 4 types: scaly type, black dot type, Curion, and Phoebus. Scaly type, caused by Trichophyta and Microspora. Black dot, Trichophyta, Curion, Trichophyta microspora, Phoebus, Trichophyta. Epidemiology: scaly and black dot types are in children only, while Curion and Phoebus are in children and adults. Differential diagnosis of scaly type is psoriasis and seborrheic dermatitis; in black dot, alopecia areata and Curion abscess. The course: no scar in scaly type or black dot type. In Curion, there is cicatricial alopecia if not treated early, and Phoebus cicatricial alopecia. Then we have the clinical picture. Scaly type, single or multiple bald patches on the scalp with fine grayish-white scales, loose hair break off, stumps about 3 mm long that can be easily pulled out. Black dot type, hair break off at surface of the skin showing black dots. Curion, boggy swelling with follicular pustules. Favus, yellow cup-shaped sulfur crusts which form around loose hairs, diffuse loss of hair replaced by fibrous tissue. Diagnosis, clinical examination or culture on Savarod's agar medium for 2 weeks. Direct microscopic examination using 15% potassium hydroxide to identify hyphae and spores. Wood's lamp give yellowish green fluorescence in some species. Then we have Tinea corporis or Tinea circinata. Clinical picture appears as single or multiple well-defined annular patches with active red vesicular scaly edge and healing center. Sometimes they coalesce to form polycyclic pattern. Itching is common. Differential diagnosis from herald patch of Pityriasis rosea. Tinea cruris, predisposing factors are heat, friction, obesity, diabetes mellitus, and excessive sweating. Clinical picture, scaly erythematous lesion involving crural area, groin. They tend to spread peripherally with active papillovesicular border, relatively clear center, annular pattern. Then they extend to gluteal folds and buttocks. Itching is common. Scrotum is not involved due to the antifungal effect of fatty secretions of sebaceous glands. Differential diagnosis, candidiasis, flexural psoriasis, seborrheic dermatitis, and erythrasma. Tinea barbae, source of infection, farm animals or barber's instruments. Clinical picture involving is mostly one-sided on the neck or face. Lesions are similar to Tinea circinata corporis or showing pustules like curoin with loss of hair. Tinea pedis, predisposing factors are excessive sweating, moisture, and diabetes mellitus. Source of infection, wet floor boards or infected shoe wear. Types, interdigital type, hyperkeratotic type, and vesiculobullous type. Differential diagnosis of vesiculobullous type is eczema. Hyperkeratotic type is psoriasis, and interdigital type or the athlete's foot. 2 webs, particularly the third and the fourth, are white macerated malodorous, usually unilateral, with tendency to recur and being chronic after treatment. Differential diagnosis, candidiasis, erythrasma, interdigital bacterial infections. Tinea mannum, unilateral on the palm, well-defined scaly erythematous patch with tendency to peripheral extension. Tinea oniguum or onychomycosis, yellowish whitish discoloration of lateral and distal borders of the nail plate with thickening and or brittleness leading to onycholysis. 1 or more fingers or 2 nails may be involved, usually starting unilateral. Treatment. Tinea capitis, systemic therapy. This is a backbone of treatment. Rhizofolvin 12.5 mg per kilo per day for 6 to 8 weeks, or allylamines. Topical therapy, tincture iodine 1 to 2%, Whitefields ointment, azole derivatives, selenium sulfide suspension or ketoconazole shampoo twice weekly renders the patient non-infectious early. Topical therapy is also used for prophylaxis in contacts. Tinea cruris or Tinea axillaris, avoid predisposing factors. Topical therapy, antifungals twice daily for localized cases. Systemic therapy, rhizofolvin, allylamines, azole derivatives for 3 weeks for extensive or resistant cases. Tinea barbae, systemic therapy, rhizofolvin, allylamines, azole derivatives. Topical therapy, antifungal agents. Tinea pedis, avoid predisposing factors. Topical therapy, Castiani paint, tincture iodine 1 to 2%, topical azoles or terbinafine. Systemic therapy for extensive and recurrent cases. Onychomycosis, systemic therapy, terbinafine 250 mg daily for 6 weeks for fingernails and 12 weeks for 2 nails, or itraconazole. Yeast. Diseases caused by the yeast are Pityriasis versicolor and candidiasis or monaliasis. Pityriasis versicolor, it's a very common superficial mycotic infection, frequent in tropical climates and summer, occurring in young adults with familial predisposition. By lipophilic yeast, Malassezia furfur, the pathogenic form of Pityrosporum orbicular, the normal commensal yeast of human hair follicles, under certain conditions transformed into the pathogenic form, which is Malassezia furfur. Clinical picture, sharply demarcated macule covered by fine briny scaling, may be hyper or hypopigmented or erythematous, starting on the neck, upper parts of the chest, back and arm. In extensive cases, it spreads to face, abdomen, and other parts of the body, usually asymptomatic. Itching may be present. Recurrences are common in summer due to heat and humidity. Diagnosis: clinical Wood's light or microscopic examination of skin, scrapings of scales treated with 10% potassium hydroxide showing mycelia and spores, spaghetti and meatballs appearance between epithelial cells. Treatment: systemic, topical, and prophylactic. Systemic: azoles, fluconazole, 150 mg capsules, 2 capsules per week for 2 to 3 weeks. Itraconazole, 100 mg twice daily for 1 week. Topical therapy: zinc paraffin shampoo, selenium sulfide 2.5% suspension or shampoo, imidazole derivative spray, lotion, cream, or shampoo. Prophylactic treatment: selenium sulfide shampoo once per week. Candidiasis or moniliasis caused by Candida albicans, dimorphic organism which can be a commensal, and it has a mycelial form, pathogenic form. Predisposing factors: under certain conditions, the organism is shifted from its commensal form to its mycelial pathogenic form. This shift is predisposed by trauma, friction from obesity, moisture, sweating, debilitating diseases such as malignancy. Drugs: corticosteroids, cytotoxic, antibiotics reduce the competing flora during antibiotic therapy, favors candidal growth. Conditions associated with low resistance such as diabetes mellitus, Cushing syndrome, anemia, AIDS, pregnancy. Clinical types: cutaneous and mucosal candidiasis. Cutaneous candidiasis: superficial vesicles which coalesce and rupture, giving well-defined red eroded areas with white fringed edge and satellite vesicles. Candidal intertrigal, and paronychia and onychia. Candidal intertrigal on groin, axilla, and inframammary areas. Interdigital: maceration with sodded skin between finger webs, commonly affecting space between ring and middle fingers because it's anatomically narrow. Angular cheilitis, maceration affecting angles of the mouth. Differential diagnosis: streptococcal infection and riboflavin deficiency. Napkin dermatitis, maceration and erythema with sharp border beyond which are satellite papules and vesicles which occur in diaper area in newborns and infants. The depths of the flexures are usually affected, differentiating it from dermatitis due to contact with wet napkins where the depths of flexures are spared. Paronychia and onychia. Occupation is very important predisposing factors such as housewives and cooks. Nail fold is swollen, red, slightly tender, oozing pus. Nail plate showing discoloration, transverse ridging, and corrugation. Differential diagnosis: pyogenic paronychia. This condition is chronic without throbbing or pointing in candidal paronychia. Mucosal candidiasis: we have whitish pseudomembrane oral thrush, vaginal vulvovaginitis thrush, and balanitis. Oral thrush in mouse occurring in infants, debilitating adults, and HIV patients. Balanitis, glans penis in uncircumscribed males and diabetics. Vulvovaginitis, pruritus vulvi with whitish patches on vulval and vaginal mucosae, and thick, creamy, white vaginal discharge. It's commoner in pregnancy, diabetics, and after systemic antibiotics. Treatment of candidiasis: avoiding predisposing factors. Topical therapy: Castellani paint and genitin violet 1 to 2%, genistatin creams, and vaginal tablets or imidazole derivatives. Systemic therapy: mycostatin oral suspension and azoles such as fluconazole and itraconazole. And this concludes our chapter for today: fungal and viral infection.